Welcome back to MedTech Insights. Today I'm joined by Chris Scarisbrick from Sectra. He is the Customer Operations Director and the Deputy Managing Director for UK and Ireland. Chris, I want to start off by asking about radiology. Radiology was one of the first NHS disciplines to go digital with the widespread adoption of picture archiving and communication systems around 2006. How did that early head start shape expectations for digital transformation in other areas of the NHS?
Okay, Ollie, funnily enough, the time that happened was about the time that I qualified as a radiographer. So I qualified as an analog trained radiographer, and then I moved into the brave new clinical world, got my first job on a digital system. So I was right in the thick of it, I think, on the front line of that digital transformation phase. So it's been a really interesting career, actually, in radiology and digital imaging, generally speaking. But I think radiology packs came along and it was transformational. It wasn't just a technical transformation, but it was a cultural transformation as well. It proved that clinicians and radiologists would adopt clinical tools if they genuinely improved workflow. And that really set a benchmark, I think, for future projects in the NHS. I think it was around about into the early noughties. Film was eliminated entirely almost overnight. Radiologists gained remote reporting, instant retrieval of images, structured archiving, and it was a proof of concept for whole hospital digitisation. And I think part of the success really was that radiology was the ideal candidate for digitisation at the time. It was a highly visual, data driven discipline, a single professional group. We were also very lucky in radiology that we had a very mature standard DICOM and a clear return on investment. We were eliminating film costs by the implementation of PACS. And I think it may have given NHS leadership maybe an overly optimistic template. Subsequent programs, I guess, we've seen difficulties digitising other disciplines because that strong standard that existed in radiology and had existed for a long time in radiology isn't there. I think that was one of the challenges that we saw in future digitisation exercises. We really had to work to accelerate the adoption of the underlying standards, which then provided the framework for accelerated adoption of digital workflows.
Now, official policies push for a cloud-first approach, but cloud adoption in the NHS has been slow up until recently. What has changed to make the public cloud essential for today's demands?
Okay, I think there are a few things here, Ollie, actually. I think in the UK, we had, obviously, it was a global pandemic, but I think what it did do is it exposed the fragility of on-premise only infrastructure and it compressed years of hesitation into months of necessity. So suddenly, radiologists needed to work remotely. And I think that those trusts that had a remote infrastructure kind of had a head start on that. They were able to accommodate the demands on the workforce that much easier, and specifically those that had cloud first architectures. But I think as well as the pandemic, we were fortunate in the UK that some policy shifts had really hardened over several years. The long-term vision for the NHS, what good looks like, the Topol review, a plan for digital health and social care, etc. They all advocated for a cloud-first approach, and more we were seeing that NHS leadership needed to justify why they weren't going to cloud-based infrastructures and justify that decision if they chose not to. So it was a bit of a perfect storm for the adoption of cloud in the UK, really. And that is something that we see compared to perhaps other European regions. We see a much more aggressive adoption of cloud here in the UK than we do in other regions globally. I think there are a few other things really that have helped with this cultural technology shift as well. The formation of the ICSs, the integrated care systems in 2022, created a new incentive for cloud. Shared infrastructure across multiple trusts is practically impossible to deliver on premise. Like, whose server room does this infrastructure live in, for example? But that sort of thing is trivial, solvable in cloud. So I think that ICS level packs and shared diagnostic platforms have been a direct accelerant, really.
Now, along the same lines, with the increase of cyber threats. How does a cloud-first approach change the risk profile for a trust? And for patient data, how safe is essentially outsourcing infrastructure to global cloud providers?
Okay, good question. I think cloud, Ollie, it doesn't eliminate risk, far from it, but it does transform it. I think the question shouldn't be, is it safe, but is it safer than the alternative?
Mm.
And I think for most trusts, the answer is increasingly yes. I think hyperscalers, the Microsoft Azures of this world, invest billions in redundancy and multi-region failover that no NHS trust could replicate, really. And the alternative would be hundreds of individually managed on-premise systems, which I think creates distributed fragility, not resilience. And I think well architected cloud platforms use multi region active configuration, which really helps to mitigate and eliminate some of that risk. So I think the honest answer is that concentration risk is real, but the mitigation is good architecture, not avoiding cloud. I think something that we're particularly home to here in the UK is in a post WannaCry world is ransomware attacks are very damaging. I think in healthcare, we do have a target on our backs. And I think one of the things that public cloud infrastructures do provide is the opportunity to leverage immutable storage layers. And what that means is once the data has been archived, it cannot be changed. It cannot be updated. It is write once, read many. Even Microsoft themselves, where the data is stored, couldn't alter the data if they wanted to. So it's that last line of attack, really, or the last line of defense, I should say, against ransomware type of attacks.
Now, my next question I think is quite interesting given your background in radiology. Pathology is currently undergoing the same digital revolution that radiology did 20 so years ago. What lessons are being applied from that radiology playbook to ensure things go smoothly?
Yeah, and that in itself has been a really interesting journey for me personally, and indeed my colleagues. When I first started here at Sectra, we were a radiology company, and over the years, we've very much changed into an enterprise image management vendor. Our CEO, Torbjörn Kronander, obviously he's a Swede, we are a Swedish company, often uses the analogy that we should skate to where the puck is going to be. That's an old ice hockey analogy. Wayne Gretzky, I think, is the name of the skater that he references. And I don't think he was ever considered to be the quickest, the most skillful, but the secret to his success, and he was considered the best player in the world, was that he skated to where the puck was going to be. And that's what Sector have tried to do over the years. It's something that we've lived by. So we've had digital pathology in our solution now for about 8 years or so. We're really mature in that space. And I think lesson one would be don't try to boil the ocean. Radiology succeeded, as I said earlier, because DICOM provided a universal standard. Pathology is adopting DICOM for whole slide imaging, but implementation varies. And I think NHS trusts need to be insisting on open standards from day one. And I think another lesson would be that get that multidisciplinary buy-in from the start. I think those early PACS rollouts, indeed the ones that I was involved in as a frontline radiographer and PACS manager, often the ones that did the best did so because they weren't treated as a radiology department project. In reality, they affected every clinical team that either ordered or consumed radiology imaging. Digital pathology has a similar problem. It's often led by pathologists, but the downstream consumers, the oncologists, the surgeons, the MDT coordinators, need to be co-designed from the start. If the MDT viewer doesn't show digital slides in the same workflow as radiology imaging, then a good part of that integration is lost.
Moving on to integrated diagnostics, this was once a nice to have concept. Where in the NHS is it becoming daily practice, and are there any remaining barriers?
I think we'll constantly be pushing barriers and we'll move from one thing to the next in the pursuit of these world-class leading workflows. But I think the MDT is where integrated diagnostics has always happened informally. The challenge is making it systematic, scalable and data-driven rather than dependent on the right people being in the room, let's say. And I think The way that the NHS is setting themselves up in recent years puts much more emphasis on integrated diagnostics as well. So, diagnostic hubs, a key commitment in the NHS long term plan, for example, are designed precisely for this co located, virtual networked radiology, pathology, cardiology, endoscopy, all under the same roof, all under the one governance structure. And I think as we move towards those types of models of care and diagnosis, the gold standard for integrated diagnostics becomes a single unified report that synthesizes imaging findings, histopathology, biomarker results, produced collaboratively rather than in separate siloed departments. And this is a standard of care in some leading cancer centres already today globally. Not seeing that quite so much in the UK yet, but I think it's going to come. So, yeah, it's a constant evolution of the workflow. And with more that we can bring these disciplines together to provide feedback loops, to reinforce diagnosis and provide additional sources of information to those creating the diagnosis is key, really. And I think there's a cultural barrier, perhaps. Your question was around what barriers still exist. I think there's a cultural barrier. Radiologists and pathologists have traditionally operated in parallel, not in dialogue, and breaking down those professional silos is as hard sometimes as breaking down those IT silos. So I think more and more that we share the same infrastructure, we share the same language, the more and more we'll break down those technology and perhaps as importantly, the cultural barriers. There are a number of areas where this is working well in the NHS, certainly the likes of Greater Manchester, Northern Ireland, down on the south coast across Swash, and several regional cancer centres already benefit from live integrated diagnostic models.
Keeping on the diagnostics side of things, how do regional approaches ensure that a patient in a rural setting receives the same speed of specialist diagnosis as someone in a major London teaching hospital?
Yeah, this is something where the technology really does help, and we're delivering a national solution across Scotland as we speak. And geography is a big issue to overcome in Scotland, but of course, closer to home in England as well. Geography should determine where the scanner and the imaging capacity is, not where the expertise is. And cloud based reporting networks have made specialist diagnosis genuinely location agnostic these days, in my opinion. And I think the NHS can cite some really good examples of where that comes into play. If we look at the NHS stroke thrombectomy network, it's arguably one of the best real world proof point for rural equity in specialist diagnostics globally. So this is where CT perfusion can happen at a district general hospital, for example. It can be read remotely by a specialist that sits in a stroke network. Perhaps some AI triage can happen before a radiologist or a specialist has even been called out to do that digital review. And then if thrombectomy is required, that patient can be fast tracked to the right place to make that happen, because we know this is a supremely time sensitive condition. So, yeah, I think there's lots of examples. And I think even if we look at more long standing models such as Nighthawk and teleradiology type models, really well established for out of hours reporting, but the same principle now applies 24/7. So, a rural DGH, for example, can access subspecialist neuroradiology or interventional expertise remotely by benefiting from these teleradiology networks that have been created.
Now, we're talking about digital throughout this whole interview, so of course AI is going to come up at some point. You've previously argued that AI should be invisible to the user. How does Sectra ensure that AI aids the workflow for an already overstretched radiologist?
Okay, good question. One of the questions I always ask about an AI implementation is, did it add a step or did it remove one? Because if a radiologist has to go looking for what the AI thinks, you've added cognitive load to somebody who's already reading hundreds of studies a day, probably. The value only lands when AI output is simply there in the right place at the right moment in the radiologist's own frame of reference. So to me, invisible AI means AI outputs arrive in the reading workflow as annotations, structured findings, work list prioritization, for example, not as a separate application that the user needs to consult. It's about reducing that cognitive load and friction in the workflow. Through our open platform here at Sectra, our amplifier platform, we allow third-party vendors to deliver results into the PACS viewer natively. The radiologist sees those AI annotated images, not a link to another system. So I think that's really key. And that's really what I mean about invisible AI. It needs to drive efficiencies, reduce that cognitive load, and allow the radiologist to do more, not less.
Now, the NHS 10-year plan, it pledges to integrate genomic data with clinical and diagnostic data. How do you envision a genomic record living alongside traditional imaging?
Yes, this is a new frontier, really. I myself am very much now learning the language of the genomics department. But to my mind, a genomic record, it's not like an X-ray that has decreasing clinical value over time. It's a reference document that informs every subsequent clinical decision for life. So the infrastructure challenge is persistence and linkage and queryability. It's not just the storage. Today, we see a lot of manual work involved in bringing genomic and imaging data together. As the burden of genomic testing increases, so does the need to industrialize that process, making it much more robust, less fragile, more automation with feedback loops built into the core. Typically, what we've seen in genomics departments all around the world is they're kind of managed quite informally. But more and more today, we are seeing an increase in sequencing requests. We're seeing a need for radiology data to be assessed in concordance with the histopathology and the genomics. That conflation of the different data sources ultimately could and should lead to a much higher quality diagnostic outcome. And I think here we need to draw the line as well between germline and somatic data as well. The two fundamentally different data types. Germline data is inherited variants present in every cell, relevant for the lifetime of the patient and the hereditary risks. Somatic data are mutations acquired in tumor tissue. They're similar yet separate workflows, and we need vendors like Sectra are designing our solutions to be able to differentiate and work with these different types in the day-to-day clinical, because we know that personalized medicine and population health are some of the things that are really going to help to drive efficiencies in the NHS moving forward.
And of course, by 2035, the goal is for genomics to inform half of all healthcare interactions. How must the diagnostic IT infrastructure evolve to handle the massive data payloads that whole genome sequencing will bring?
Yeah, and again, this sits nicely with the cloud conversation that we've been having. I think tiered storage architecture is now essential. Hot storage for active clinical use, interpreted variants, structured via resources, for example. We've got warm layers for more recent raw sequences, and we've got cold and archive layers for historic whole genome sequencing data. So cloud object storage, such as Azure Blob, with lifecycle policies is probably on a practical level the answer. But I think what we need to be doing, and what the NHS needs to be doing, is making that interoperability investment now, because it will pay dividends later. Every system deployed today that doesn't support HL7, FHIR, etc., is a future integration problem. And the NHS procurement framework should mandate that now as they are procuring these systems.
Well, that's everything for my questions. Is there anything else you'd like to add?
Nothing for me. Thank you, Ollie.
Thank you very much for your time. And if anyone wants to know more about Sectra, where can they find you?
I'm always around. Ollie, you've got my contact details, which I'll be happy for you to share with the collateral.
I can put them up on the screen.
By all means, I'll be happy to take any queries from anybody.
Perfect. Thanks very much for your time.
Thank you, Ollie. Bye-bye.